Good morning. I'm Dr. Surendra Bhati, Associate Professor, Department of Dermatology. Today we will be discussing the topic psoriasis. So what all we are going to discuss? Its introduction, epidemiology, etiology, pathogenesis, history, morphology, morphological types, distributional variation, scoring system in psoriasis, histopathology, comorbidities, differential diagnosis, and management of psoriasis. So psoriasis is a complex chronic multifactorial inflammatory disease that involves hyperproliferation of keratinocytes in the epidermis with an increase in the epidermal cell turnover. Various environmental, genetic, and immunological factors appears to play a role in psoriasis. Psoriasis is characterized by red, scaly, sharply demarcated, indurated papules and plaques of various sizes. Almost 2 to 3% of all population is infected with affected with psoriasis, and the female to male incidence is similar. So the major susceptibility locus is 6p21, also called as source S1 gene. Other loci are source 7, source S4, source RS3, and source 2. So what factors play a role? These are systemic chronic inflammation, hereditary, source 1 gene, HLA-CW6 association, various environmental factors, and immune factors. They coalesce and interact with each other and leads to the pathogenesis of psoriasis. There are two hypotheses in pathogenesis of psoriasis. The first is keratinocyte hyperproliferation due to immunological response. Cytokines released by T lymphocytes and Langerhans cells may further stimulate the inflammatory cells to cause an increased rate of epidermal cell turnover. Epithelial cells themselves produce cytokines which promote proliferation of epithelial cells and attract lymphocytes. What are the triggering factors? Trauma can be mechanical, chemical, radiation, infections like streptococcus, staphylococcus, HIV, stress, alcohol, smoking, metabolic factors like hypocalcemia and sunlight. Sunlight is usually beneficial in psoriasis, but in some cases it may cause exacerbation. Certain drugs also triggers the precipitation of psoriasis or increase the severity of psoriasis. These drugs are beta blockers, lithium antimalarials, NSAIDs, ACE inhibitors, antibiotics, interferons, terbinafine, benzodiazepines, digoxin, clonidine, amiodarone, quinidine, gold, TNF alpha inhibitors, imiquimod, fluoxetine, and cimetidine. So now going to the morphology of psoriasis. The lesions are erythematous, scaly papules and plaques. Characteristic lesions include well-demarcated erythematous plaques with adherent silvery white scales. Cardinal features are erythema, induration, and scaling. The most common type is psoriasis vulgaris. Sites, the most common sites involved are extensors, elbows, knees, scalp, lumbosacral area, intergluteal clefts, palm soles are also involved commonly. New lesions can come at the site of trauma, which is called as Koebner's phenomena. And there is exacerbation of psoriasis in winter and improvement in summer. So a sign called Osprey signs occurs in psoriasis, which is a test for diagnosing psoriasis. On scraping a lesion of psoriasis with a blunt glass slide, scales are silvery white scales are observed, followed by a glistening transparent membrane. On the removal of this membrane with the membrane which is called as Bulkley's membrane, multiple small bleeding points are observed. This sign is absent in pustular psoriasis and inverse psoriasis. Also, Grattet test is done, which is while eliciting the Osprey sign, the characteristic coherence of scales seen as if one scratches a wax candle, also called as candle grease sign. Borno's ring. A blanched halo of approximately uniform width surrounding psoriatic lesion usually follow phototherapy or cold tar therapy. Its local inability to synthesize prostaglandin E2 in response to ultraviolet lights stimulus resulting from the presence of an inhibitor of prostaglandin synthesis. So you can see the auspate signs pinpoint readings. You see the white ring around the psoriatic lesion called as Warnoff ring. So what are the types of psoriasis? On the morphological basis, there is chronic plaque psoriasis, which is the most common type, also known as psoriasis vulgaris, typically appears with erythematous plaques covered with silvery white scales. The plaque coalesce and cover a large areas of skin. Common locations include trunk, extensor surface of limbs, and scalp. Gutted psoriasis. In Greek, gutted means droplet, characterized by numerous small oval spores distributed in a centripetal fashion. These account for 2% of the cases. It is associated with streptococcal throat infection, is common in children and have good prognosis. About one third patient develop plaque psoriasis eventually. So you can see the images of chronic plaque psoriasis. We clearly well defined erythematous plaques with scaling. See the small droplets type lesion in gutted psoriasis. Now see, we will be seeing pustular psoriasis. Crops of pustules on erythematous base. Pustular psoriasis can be divided into localized and generalized. In localized psoriasis, there is palmoplantar pustulosis and acrodermatitis continua of Halapio. In generalized psoriasis, they are of 5 types: acute or von Zombush, generalized pustular psoriasis of pregnancy, infantile and juvenile, circinate, and localized. Triggering factors are sudden withdrawal of systemic or potent topical steroid and infections. Now we'll be discussing about erythrodermic psoriasis. Erythrodermic psoriasis is generalized edema and scaling involving greater than 30% body surface, 90% body surface area. Develops from chronic plaque psoriasis or unstable psoriasis. It is precipitated by infections, tar, drugs, or withdrawal of corticosteroids. It is accompanied by fever, chills, hypothermia, and dehydration, secondary to the large body surface area involvement. You see the pustular lesions of pustular psoriasis. See the whole body involvement in erythrodermic psoriasis. Then we'll be seeing follicular psoriasis. These are scaly follicular papules over the trunk and extremities. These are present at the opening of pilosebaceous follicles. Linear psoriasis, there is linear distribution of psoriatic lesion along the Blaschko's line. Annular psoriasis, clearing in the center of the plaque. Rheumatoid psoriasis, which has limpet-like or cone-shaped lesions. Elephantine and osteitis psoriasis, in which lesions resemble oyster shells. Rheumatoid plaques are small, 2 to 5 centimeters in diameter and highly hyperkeratotic, resembling limpet shells. Osteitis psoriasis present with hyperkeratotic plaques with concave centers similar in shape of oyster shells. And now the classification according to the distributional variation. According to the distribution, then we can have scalp psoriasis, palmoplantar psoriasis, nail psoriasis. Nails are involved in 25 to 50% patient which have pitting, onycholysis, subangular hyperkeratosis, splinter hemorrhages, and oil droplet sign. Mucosal psoriasis, inverse psoriasis, it spans a typical extensor surface, affects intercutaneous areas like axilla, inguinal folds, inflammatory creases, areas with minimal scaling. Then see the scalp psoriasis, palmoplantar psoriasis. You see the pitting which is coarse in nails. You see the lesions in inverse psoriasis below the breast. So now we're discussing the histopathology of psoriasis. There is parakeratosis, microabscess of Monro in the horny layer, absence of granular layer, regular elongation of reticulates, which is also called as camel-foot sign. Suprapapillary thinning, spongiform pustules of Kubuch, dilated and tortuous capillaries in derma papillae, and superficial perivascular inflammatory infiltrate. What are the comorbidities associated with psoriasis? Psoriasis is commonly associated with metabolic syndrome, and the metabolic syndrome constitutes cardiovascular diseases, diabetes, psoriatic arthritis, mood disorders, anxiety, depression, suicide, Crohn's disease. What are the differential diagnoses? Seborrheic dermatitis, nummular eczema, tinea corporis, lichen planus, secondary syphilis, psoriasis rosea, drug eruptions, tinea angium, and mycosis fungoides. These are all differential diagnosis of psoriasis. How can we manage it? Psoriasis is a chronic disease that has a significant effect on quality of life. Management involves addressing both psychological and physical aspects of the disease. What are the psychological aspects? Laying out reasonable aims of treatment, patient education, counseling, and treatment with psychoactive medications. General measures like avoidance of trauma or irritating agents, weight reduction in obese patient, reduce intake of alcoholic beverages, reduce emotional stress, sunlight and sea bathing improve psoriasis except in photosensitive psoriasis. First, we will be dealing with topical therapy. In topical therapy, emollients are the most important things, minimize the symptoms of itching and tenderness, and help to prevent irritation, and thus the protection for subsequent cauterization. TAR, it is an anti-proliferative effect, and 2% or 3% of crude coal tar. Alternative is 4 to 10% LCD, which is like a carbonate detergents, a tar distillate. A old regimen, Bokerman regimen, was first followed, in which coal tar is applied on an UV in a patient for 24 hours in combination of erythrodermic dose of UVB. In modified Bokerman regime, coal tar is applied for 5 hours per day in combination with narrow-band UV in patient with moderate to severe psoriasis. Other therapies are uh, anthralin, which has in-gram regimen in patients are treated with tar bath, suberythrometic UV, and then diethanol in laser paste is applied on the plaques, starting with the concentration of 0.05 to 0.1% and increase cautiously to reduce irritation up to maximum concentration of 4%. Other topical treatments are salicylic acid in combination with topical steroids, topical vitamin D analogs, topical retinoid, tazotine, and topical cancellin inhibitor like tacrolimus and pimacrolimus. UVB phototherapy is generally used in psoriasis and responsive to topical therapy. Then we have targeted phototherapy, excimer lasers, lamps, and targeted UVB therapy is selectively target affected lesion of psoriasis while leaving unaffected skin untreated. Highly effective, can be used for resistant localized lesions such as scalp and palmoplantar psoriasis. PUA chemotherapy, systemic surendra plus ultraviolet is indicated for adults with generalized psoriasis who are resistant to topical therapy. Here, 8-methoxysurelin, which is 0.5 to 0.6 milligram per day is given. What are the systemic therapy we can use? A general principle, as a general principle, a basic body surface area of 10% has been traditionally. Nowadays we can have 20% body surface area involvement more than we traditionally use systemic therapy. A patient of, however, a subset of patients with limited disease having debilitating systems with significant negative effect on quality of life can also be treated with systemic therapy. What the systemic therapy we can use? We can use methotrexate, apremilast, cyclosporin, acitretin. Second line systemic agents are azathioprine, fumaric acid, esters, hydroxyurea, leflunomide, mycophenolate, and morphine. Systemic steroids should not be used in routine cases of psoriasis. Its role of management is otherwise uncontrollable erythroderma and causing metabolic complications. Nowadays, there is newer agents called biological agents are used in treatment of psoriasis. Biologicals use should be restricted to the patient with severe disease defined by PASI score of 10 or more A body surface area of 20% or greater than where passing is not applicable, and DLQI of greater than 10. Patients who have failed to respond or who have a contraindication or who are intolerant to other systemic therapies such as cyclosporin and methotrexate. Biological agents which are licensed for treatment of psoriasis vulgaris are etanercept, infliximab, adalimumab, ustekinumab, and sequinimab. What are the future therapies which can be used? Anti-tumor necrosis factor therapy, cetolizumab pregol, Janus kinase inhibitor, tofacitinib, interleukin 23 inhibitors, sonelokimab, and mirigizumab. So that completes our psoriasis. Thank you.